right, if we could take our seats, we're going to get started on this hospital CEO panel. And I want to introduce us pretty quickly. My name is Andy Miller. I'm a healthcare journalist for the last 30 years, and believe me, the last 2 years, I've learned a lot about a certain virus, as we all have. It's been a little bit difficult to report on, but it's always been interesting. To my right is Kevin Brown, who's president and CEO of Piedmont Healthcare, which is based here in Atlanta, but also has hospitals really around the state now. They've expanded quite nicely. Dr. Tom Owens, next to him, is president of the Duke University Hospital and a vice president of the Duke Health System. And then Jonathan Watkins is regional president of the Cancer Treatment Centers of America's campus here in Georgia. He is, which has also been acquired by a nonprofit in California called City of Hope. So one of the first things that I heard about during the pandemic was the fact that nurses were hard to find. I mean, they were getting burned out, they were retiring. Many of you already know this, but I just had a conversation recently with a father of a young nurse who was coming out of school, and she was planning on doing a travel nurse job for a couple months, and she would get paid as if that was going to be 10 months long. So we see the challenges about the labor force, and that's the first topic we're going to talk about. We want to talk about retention and recruitment. Kevin, do you want to start us off by telling us what you've seen in your system?
Sure, and thanks for having me, and I hope you have a couple hours. No, it's been an interesting journey the last 2.5 years for sure. Who would have known that at the end of this journey we would end up with this massive shortage? We started the journey, obviously. There's been a nursing shortage my whole career, so it is a topic that's always been in the forefront, but it's been exacerbated by the COVID pandemic, and a lot of the nurses left the nursing field, or they left hospitals to go work in schools or other things that didn't require maybe the pressure associated with working in our acute care facilities. We have about 27,000 employees and probably about 9,000 nurses or so, and we have probably 3,000 nursing openings. And it really is the crux of our ability to add capacity right now is just because we can't staff. And the nursing shortage has created kind of a financial crisis for us and for other organizations. A nurse that used to make $45 an hour within our system is making 25% more. And if they take an agency job at the heat of the COVID crisis, they could get $225 an hour. And as Andy said, make a year's salary in a 16-week assignment or so. And it's also a factor of, again, this massive shortage, so there was this massive demand, and it's a lifestyle opportunity for those working too, where work a 16-week contract, pretty much guaranteed you can get another 16-week contract, 2 or 6 or 4 if you want to take some time off in between. At Piedmont, prior to the COVID pandemic, we would spend on an annual basis about $20 million a year on agency nurses. This last fiscal year, we spent $400 million. And the delta is enormous, obviously. The other thing is a large portion of that $400 million did not go to the nurses. 35% went to the agency. So it's probably been a good business to be in if you were able over the last few years. But it is slowly kind of coming down. It's forced us to open our own agency internally to try to I guess at least wipe out the middleman portion of the expense. But nursing is a real challenge, so we're working really hard on recruitment, retention, And then also looking at different care models to staff the units that give the nurses that we do have a lot more support around them so that they can, from a quality and a safety perspective, take care of a larger patient base. So yes, it's been a real challenge. And so the nursing shortage really has created a real financial stress for us and everybody across the country.
Tom, what are you seeing in Durham, North Carolina?
Unfortunately, Andy and Kevin, it's very much the same story. So this is a national crisis, it's not a regional crisis, and we could alter the numbers slightly, but it's the same story at Duke and Duke Health and for our peer institutions in North Carolina. What I would just add to the comments, in addition, Kevin very eloquently outlined the challenges we face, but as he said, we anticipated a nursing shortage. There's been a nursing shortage and a healthcare staff shortage for a while. This accelerated that shortage and really changed the complexion in ways that we didn't anticipate. And so, as Kevin mentioned, expectations of the workforce are changing. People have options to work differently, to work remote, to work and travel, see the world. It's actually, I've thought about going back to nursing. And if there's any nurses in the audience, please see me afterwards. We can talk about great jobs at Duke.
They're better at Piedmont.
There's competition for
That's
employees on the panel here.
But I think the other thing, we have to be self-reflective, and Kevin talked about improving the work, and healthcare has been slow to change. We're highly regulated. We've done things, at Duke, we do things the Duke way, and that can mean good things, right? A tradition of excellence. It can also mean somewhat static nature of our business. So I think this is also a call to action for healthcare to reconsider waste, inefficiency, frustrations, limitations in our systems and the approach that we take. How can we value the workforce, keep them connected to our organizations and to the practice of nursing, get them to the bedside more, and not just nurses, but other caregivers, get them away from computer screens and doing more of what brings joy and meaning to work. And that I think will be essential to drive future workforce into nursing, into healthcare, as opposed to other industries that offer some advantages, not 24/7, not with some of the stresses that Kevin mentioned that the pandemic really emphasized. So we see it as a call to action. Unfortunately, we have a compressed time frame to work through this. But back to Dr. Califf's point earlier, by the way, he was my attending in the CCU when I was an intern. I can tell you Rob Califf stories later. But we can do this with partnership. We can do this learning from other industries, bringing other partners into our space to help us think about redesigning the work, redesigning the teams. But we've got to do this with some urgency. We don't have decades. We have months or years to do this.
Jonathan, how about what's happening at CTCA in terms of workforce? And is it more than nurses? Are there other shortages?
Definitely, across the board. So similar to my colleagues, we're experiencing it within the cancer space as well. The one thing, though, we've been focused on really is retention, recognizing that the nurses that are there are our best opportunities to recruit. They're the best advocates. They're the ones that are going to get out and talk to nurses in these programs and schools. Nurses don't want to hear from a guy in a suit what it's like to work on a unit. They want to hear from that nurse that's actively treating and connecting with patients. The other opportunity we've experienced or noticed has been amongst those professional and ancillary service areas. We have the luxury and privilege of having a Starbucks in our facility, which our patients actually love. It's one of those items that has really advanced our patient satisfaction scores. But for close to a year, we couldn't find people literally to make coffee in the facility. We couldn't find environmental services workers to help keep we're a destination cancer facility for the most part, so a lot of our patients travel in and are receiving care on multiple days. So the top 2 floors are a hotel, very nice hotel, by the way. And we couldn't find staff to even keep it clean and keep it running, so we had to shutter services and rooms there. I see my VP of Operations, Michael Schrick's, in the building. He was consistently asked and challenged, get the workforce in, get the rooms back open. He eventually got there, and we eventually got there. But yes, the challenges across the board in healthcare and staff.
I would just say we kept the Starbucks open at all costs during the pandemic.
That's good, especially early in the morning. So what are some of the solutions that you all have focused on? Some of this, Kevin, you mentioned your own staffing agency. Are there benefits? Are there work shifts that you can reconfigure? Tom, you want to talk about that? What kind of collaborations and partnerships are out there?
Sure. I think technology has been, in some ways, crippling for healthcare. As I mentioned, people spending too much time in front of systems and screens rather than patients and team members. But I think now we're at an inflection point where technology can be more enabling, and we're thinking about how can our team members interact with the technology they have in a better way. So we have some industry partnerships looking at how do we reduce the barriers to data entry or accessing information in real time, and develop much more quickly interface improvements, less typing, more speaking, and also ways for our team members to work remote where possible. Obviously, bedside caregivers need to be bedside, but there are ways we can have them work remote part of the time, doing other support roles, interacting with patients in transitions of care, working with care managers. So we've learned a lot from industry partners that did that before we did, perhaps in the space working with payers or other community partners. So those are some examples of some of the collaborations. And candidly, our organization started on a lean management and improvement journey some years back. We've accelerated that dramatically, realizing that we need a systematic approach to engage and empower all of our team members in improvement. So we've actually spent a lot of time with other industries that are not healthcare to learn how they've navigated stressors and change. And again, healthcare is unique in some ways, but frankly, I believe, at least I have stood behind for years, sort of healthcare is different. We can't learn from others a little more than we should have. And I think there are great opportunities to learn from other industries, how they've managed seismic shifts in their business like we're experiencing.
Jonathan, is it partnerships with schools and colleges? Is that helpful, and how's that working for you?
Yeah,
guys?
definitely, 100%. Our ability to connect with Emory University, University of Georgia, programs that have strong nursing programs to help cascade and generate that next group of nurses that were going to come in. But for us, again, I think the biggest focus for us was truly retention. How do we connect with the nurses, our executive team rounding, to hear directly what was going on units, to identify how we problem solve and address the challenges they were experiencing. Our chief of surgery, Dr. Anita Johnson, was an advocate and adamant that, hey, physicians, you got to treat the nurses better. There's no yelling in the OR. There's no coming down on them when things happen. Again, all those were those small nuances that oftentimes we took for granted, that a nurse would simply leave and go to another hospital or organization because of the environment, not necessarily getting out of the industry. There were those, yes, that expedited their plans to retire, but there were some that truly just left to go work home health, different organizations and agencies to get out of the environments they were in. So for us, it was how we created a culture and an environment that nurses wanted to stay in and continue to care for patients. Because for many, it's a calling. They do it because they love exactly what they do. They do it because they love the patients that they get to interact with, but it's the environment that we focused on at CTCA.
Kevin, are there incentives that are new or different that might help with retention of whether it's x-ray techs or nurses? Is there something that you guys are looking at Piedmont?
I'm not sure there's anything that's unique. Everybody is doing a sign-on bonus, retention bonuses, trying to connect, as Jonathan said, with the staff. The cost to try to compete with the agency, opportunities. I think our incremental increase in payroll of our own staff last year was about $300 million. And again, Jonathan spoke very well about the connection with the nurses. We're also trying to connect with the frontline staff, because actually the majority of our turnover actually is in non-nursing. Our nursing turnover has gone up, but not as badly as some of our frontline staff, dietary, food service, security, and those types of things where they can go work at the Amazon warehouse,
right,
and make more than they're going to make at Piedmont and be in a very different environment that probably has less stress. So we're working on all of the above. And I would just say on the partnership side of the equation, we're also working with all of the schools, the technical schools, and trying some creative solutions there. In Augusta, we have a partnership with Augusta Tech, where we're taking some space we had in one of our facilities that was vacant and increasing their teaching space through a lease and a partnership with them, where they think they can increase the enrollment of their nursing program by 200 students kind of over time. And so we're doing that community by community across the state and looking for any and all opportunities. to kind of work through this.
Shifting gears just a little bit, during the pandemic, we all know that a lot of healthcare was suddenly being delivered by telehealth. And I remember when I got diagnosed, I was on a Zoom call, and well, I tested positive first. Tom, how has that changed? How has medicine changed because of COVID?
You know, you mentioned telehealth, which is a good place to start. At Duke Health, we like to think we were advanced in our use of virtual technology for interaction, but we were dealing with hundreds or a few thousand virtual interactions a month. Overnight, like other health systems, we flipped to providing tens of thousands of encounters a week virtually. And we learned a lot from that about how, you know, could we deliver the highest quality of care without being in the same room with patients? What were the skills needed from our team members? What was the technology needed? And what was the patient experience like? Did patients enjoy that interaction? Did they feel connected to their provider? And did they achieve the outcome they desired? So that really got us thinking about, you know, how could we accelerate some of the changes that our patients had been looking for, whether that was, again, other ways of interacting like they do with Amazon, you know, self-scheduling, using apps, using tools to interact with providers and communicate more seamlessly. And could we, you know, not let a crisis go to waste and create that culture change within our team that was often the barrier to the change. Our physicians, our nurses, others who were less comfortable with that way of interacting because we grew up in an environment that was based on a direct personal interaction with patients. So we, I think, used the burning platform or the need in the pandemic to accelerate some of those changes. We're trying to figure out how we maintain that momentum now, candidly, because there's a little less pressure on some aspects of that in healthcare, and we don't want to lose momentum because we believe there's still a real advantage to interact differently. And to Dr. Califf's point earlier, you know, we work and live in a semi-rural state in North Carolina. Of our 100 counties, you know, 80 of them have many of the rural health challenges that Rob was mentioning earlier. So face-to-face interactions for us will not help us reach all of the patients that need us in our region. So that's another big area of focus for us, is identifying and reducing disparities in healthcare. And I think some of what we learned in the pandemic can really be applied there to help. Because when we're thinking about staffing capacity challenges, if we can improve health and health outcomes, avoid preventable hospitalizations and ER visits, keep people healthy in the environment, that's actually better for everybody. It's better for hospitals to avoid progression of chronic disease and unnecessary care. Better financially, better for quality reasons, just the right thing to do. So the incentives are aligned right now for us to really innovate in that space, Andy.
Kevin, how has it worked at Piedmont in terms of telehealth and changes in delivery of healthcare?
Yeah, very, very similar. You know, we went with some telehealth options kind of before COVID, and then, you know, in about 3 weeks' time, we went 100% virtual. So something that, you know, people felt wasn't possible to do it that quickly. It's amazing how quickly you can move when you've got a singular focus and everybody's is organized around getting the same thing done. So we went to virtually 100% virtual, and it's come back down now to maybe 30%. And so for me, it's told me, I thought we would stay up 50, 60% virtual visits. People want to see people face to face when they're sick, and really sick for sure. And for the low end things, are comfortable with more of the virtual type visits for the appropriate type of thing. And so for me, that physician-patient interaction, people being able to kind of touch and feel each other, and that's just never going to go away as humans. And so there's always going to be this balance between the two. And as a health system, it's one of the great things that we're able to provide this continuum of options for patients, consumers, to choose what's best for them at that time. So it's continued to grow. You know, the blessing with the pandemic was that it allowed us to move much quicker towards that future state in a very efficient way, and it gives us more options to serve the entire state of Georgia through our virtual platforms.
Jonathan, how has telehealth changed the care for cancer patients?
Yeah, it's been a game changer. So Russ didn't tell me this was going to be like therapy for me. I get to talk about all my challenges. When I joined CTCA in October of 2019, we were I guess, the coming off the edge of having our certificate of need restriction lifted that capped our patient ability to care for patients at 35% in the state of Georgia. So for us, we were excited and ready to go out and collaborate and partner and connect with other hospitals and systems right here in the state. Only for about 4 or 5 months later, the pandemic to hit, travel to shut down, and me begin to question whether or not joining a destination cancer facility was a smart thing to do at the time. But due to the tenacity and innovative nature of the physicians and staff at CTCA, we were able to accelerate our telehealth program and model, which allowed us to connect with cancer patients all across the country, ensuring that their care was not interrupted. One of the things our COVID-19 incident commander, Dr. Jeff Metz, would often remind us is, guys, cancer's not waiting on COVID. The disease is going to continue to manifest and continue to grow. So we've got to creatively figure out how to connect with that patient in North Carolina or South Carolina or
Maybe not
Texas.
North Carolina. You can leave the North Carolina patient stuff.
That were afraid to hop on planes and come visit us and see us. But it did, to your point, Dr. Owens, accelerate our willingness and thought process around collaborating with other systems. If we had patients that we're actively treating in markets where they could receive those services at home, we connected via telehealth remotely with providers, with clinicians, with physicians to make sure that that patient's care was uninterrupted. So it called for, again, a greater sense of creativity. And one of the things at CTCA we've always prided ourselves on is what we call the mother standard of care, an ability to hug and touch our patients. And we lost a little of that, but I couldn't be prouder of our ability to maintain that top 5, top 10% patient satisfaction rating during such a stressful time.
Jonathan, let me follow up. CTCA was just acquired, well, a couple of years ago, a year ago, acquired by a nonprofit, City of Hope. How do you see that changing? Will that change the operations there?
Yeah, in February of this year, in fact, we joined forces with City of Hope, as you mentioned, a large nonprofit health system centered and headquartered in Southern California. City of Hope is the number 7 ranked cancer treating institution in the nation. They have over 1,000 active clinical trials that patients are enrolled in. And they, depending on if you talk to anybody from Cleveland Clinic, are right there in the tops in terms of the number and quality of bone marrow transplants that occur across the country. Georgia, CTCA will now have access to each of those initiatives and items that I've mentioned. So it's going to expand and we'll do what we call democratized cancer care, where we work to take care closer to home. Dr. Khalif, as he was opening his remarks, he talked about the patient's geography or an individual's geography playing just as great of a role in their ability to beat and navigate certain illnesses. It's our goal and hope that through this partnership and this relationship that we will be able to connect with more patients and provide them with the same level of care that individuals that live around the corner from a City of Hope can receive all across the state of Georgia.
Dr. Califf mentioned the South in particular as having high healthcare disparities, having high levels of disease. We all live in southern states. We work in southern states. Tom, how do you see that? How do you see us as providers addressing that in a better way, or is it an insurance problem rather than a healthcare problem?
I thought you weren't going to ask me hard questions, Andy.
That's not one of my hard ones. That's softball.
Glad he gave you that one.
I'm going to phone some friends here as we answer this. All joking aside, the challenges we face in healthcare, health disparities in the Southeast as really a microcosm, but the greatest focal point of this in our country are multifactorial. So it certainly has to do with the economic environment in rural and some parts of our urban areas in the South, access to healthy food, the financial circumstances, in some cases lack of expansion of healthcare resources, lack of Medicaid expansion in some of our states. I believe there's a host of factors where we see ourselves as healthcare providers and frankly very large employers is that we have the ability to impact through the care we deliver, the partnerships with schools, sites where people are educated and receive health care and nutrition, in the environment to promote health by developing, as Jonathan was talking, working with schools to develop healthcare workers, but also as employers that we can leverage. For Duke, we're the second largest private employer in North Carolina, behind Walmart. No offense to Walmart, I love Walmart, but we have a very large footprint of people and resources, and the choices we make as employers around healthcare for our people, the way we interact with our chamber and other partners in the community to mobilize other employers to take actions that positively impact the health of their workforce and thus the health of the surrounding communities, I think is more important now than ever. It's challenging to do that at times when hospitals are economically challenged, but it's what we must do. So, Andy, we see this as multifactorial. It's a combination of the healthcare we deliver, the impact we have as employers, the advocacy positions we take, and the strong partnerships we create across healthcare, education, government, and the commercial sector. And Durham, for us, our home base, is an interesting microcosm of this, because even as an urban environment, we can track healthcare disparities by zip code and by neighborhood. We geospatially map all of our data, and I can tell you what neighborhoods are affected, and we have some hypotheses what drives that. Cultural differences, social determinants of health, access to healthy food, transportation routes, and we're starting to figure out how can we apply leverage in those areas to improve health locally and then model that more regionally. But there's a lot to do.
Kevin, you want to try to tackle that? I mean, we deliver health care, we follow health care in the South. There are challenges, much more so than, let's say, in Minnesota, for example. How do we address that?
Yeah, it is complicated, and that was a great answer. I'll just say ditto. No. It's something that, one health system or one hospital or, one clinic can't do it on their own. It is something where the communities have got to come together, because we don't have all the resources, we don't have all of the connections. It is something that requires partnership. Our piece of some of that is we've been aggressively, it kind of drives me nuts. Even this session was called Hospital something, and it drives me nuts always when I meet somebody and they say, how's the hospital going? I'm like, we actually have about 1,500 front doors between clinics and other things, and we just happen to have 22 hospitals. We have 3.5 million people that we care for. A very small portion of that 3.5 million come into our hospitals. We're a health system. And we've put more resources towards expanding access to care in all of the communities that we serve through urgent care, primary care, low-cost retail walk-in care, working with community clinics to subsidize and grow those services to make sure that at the really entry level that people have easy, quick, low-cost access to care so that they don't end up delaying care and ending up needing something much more expensive. Even virtual care, as we started, Andy, anybody can get a really low-cost virtual care visit from us or anybody else, really, in the state of Georgia. So everybody has access to care. Now it's how do we make sure that they know how to access it, and then connecting these other community resources that are out there with the greater good. But it's going to take more and more collaboration between health systems as well as other community organizations.
Jonathan, how does your organization tackle these challenges that are particular to the South?
We pray. Seriously, we, again, to both Dr. Owens and Mr. Brown's point, work to collaborate with our payers, our other providers, and frankly, our patients, as it's through patient education and community education that we will attempt and try to get ahead of some of these things. We had the privilege yesterday of collaborating with Clark Atlanta University to host a prostate cancer screening event, hence the light blue wardrobe choice today. During that event, we were able to screen over 20 men that we probably wouldn't have had an opportunity to connect with without going to where they are. Expecting and thinking that individuals are going to come into our doors is, I think, something we've really got to change. and figure out how we go directly where they are, whether it be their place of worship, whether it be sports venues, whether it be campuses and universities. We've really got to make that pivot and that change. And that's one of the things we're doing at CTCA and City of Hope.
I'd just say one other thing, Andy. Jonathan's comments made me think about, the rollout of the COVID vaccine was a great example of how the partnerships can really make a difference. We were able to reach out into the communities, pretty quickly with a very effective rollout for those that would accept the vaccine. But working with lots of different community organizations like the East Lake Foundation and others who went door to door knocking on doors to bring people into a clinic we did, for example, at the East Lake Golf Club for that community. And again, we and others in the community, everybody did it. But it was a really good example of how to connect with the communities in very short order.
And hospitals during the pandemic, early days, here, their traditional competitors got together to share information, correct? I mean, it was
Absolutely.
it was something different.
Yeah, no, and again, not a political statement, but I would thank the governor for really spearheading a lot of that. He was on the phone with us once a week during the heat of the pandemic, myself and my peers of the other large health systems, and it wasn't do this, it was what can we do to help? And that created this partnership with all of the health systems, really, that was kind of unheard of, where we collaborated with competitors and for the betterment of the community. So it really a success story. And again, it gets back to how do we tackle some of these opportunities to improve the health of those that live in Georgia by bringing everybody together for that common purpose.
Let's we've focused a lot on what's happening now, what's happened in the past 2 years, but I want to talk just briefly, get your thoughts on what are the challenges ahead. I mean, if you look 5 years down the line, God help us if we have another pandemic, right? But what do we see? Let's start with you, Tom. What do we see in terms of the biggest challenges or the biggest opportunities?
Well, Andy, we've talked about workforce, which I think is certainly one of the biggest in the economic impact associated with that, along with, the challenges of social determinants of health and declining health, frankly, in the communities that we serve. So I'll keep those as my top three. But to build a little bit on what Kevin was saying, we saw the best of healthcare, and in many ways the best of parts of our societies. We came together to tackle the greatest healthcare challenge we've experienced in this, not just this decade, this century. How do we tap into some of that energy, commitment, connection, and expertise to maintain the momentum that's going to be needed over the next 5, 7, 10 years to regain some of the health status we've lost, to regain some of the international health status we've lost? Because, again, for all of us, whether we're in healthcare or other industries, the health of our community and workforce is essential for us to be successful. We have record low unemployment. That's great and amazing, but we're also impacted by people that aren't in the workforce because of health conditions that prevent them from contributing in ways that would be good for them and good for our communities. So I think one of our biggest challenges is in this sort of post-pandemic phase, maintaining the connection, the focus, the intensity of some of the work we've done, but applying it to other problems at a time when we're tired. And so that would be one I would highlight. And then the other thing I'll just say, we talked about healthcare workers, those that have trained for years in an area like nursing, physicians, respiratory therapists. We need many people to see healthcare as a journey that they start in an entry-level role, in a technical role or a support role, and see an opportunity to grow, develop new skills, create a sustainable financial and work future for themselves, a role that brings meaning as well as appropriate financial support for their family and their goals. Healthcare has always been a place that did that to some degree, but we were more focused on people that had healthcare training and expertise, not folks that might enter to work at our Starbucks or work and keep our hospital rooms and our hotels open. And I see that as another challenge. We need to think about being a destination employer that will grow people along a journey, coming in with less differentiated skills and seeing a path to develop over time to stay with us.
Jonathan, what's the 5-year plan?
Great question, and as Dr. Owens was speaking, I was thinking, for us, again, I harken back to their comments around workforce development. For me, that's the biggest opportunity, that's the biggest challenge. When we look at and talk about oncologists, I was speaking with our chief of medical oncology out of City of Hope last week, and he was sharing with me the significant number and decrease in medical oncologists that are coming out of training interested in practicing medicine and taking care of patients. Many are moving to work into the pharmaceutical industry and other organizations that in many instances pay more, but also don't have the level of stress that comes along with it, taking care of direct patients. They're getting into research, and again, all great fields that we need, but we can't lose sight of and really, really need those individuals that are touching and diagnosing and taking care of patients. So when I think about the future of oncology and cancer care at CTCA and City of Hope, that's the thing that probably keeps me up most at night. And I will be working, I have a 4-year-old, so I'll be working a long time. So I need that to fix. Again, this is therapy. Thanks, Russ.
Kevin, what are your big challenges, big opportunities going ahead in the future?
Yeah, more of the same, but I would say, we've been very focused on, first and foremost, quality and safety. And through driving performance and quality and safety, we've seen enormous efficiencies come out of the system to the tune of, we've taken out maybe $500 million of expense through primarily through the improvements in the quality, reducing hospital-acquired infections, and we just have never lost that focus even through the last 3 years of COVID, which made it more difficult, but we're relentless about that. And we're also relentless about really trying to change the experience for the patient that's coming through the system. All of us know somebody who's gotten diagnosed with something, and where do I go, who do I call, how do I get in? It's Friday at 5 o'clock, and now they have to think about it all weekend. And we're creating this integrated care system that it doesn't matter if you need primary care, urgent care, retail care, or a heart transplant, that you can stay within the same system, and everybody knows what's happening with that consumer, that patient through that journey, and that we use technology to make that journey a lot more seamless. So you're not picking up the physician's card and saying, I'll try this number, and they say, you're on hold, and then I'll get you in 6 weeks. It's how do we get it more of an integrated product that's built around the needs of the consumer, the patient, versus the needs of all these different pieces. And we've been working really hard at putting all these pieces together, and now we're going to stitch it together more effectively. And there's also it's better care, and it's more efficient for sure. You think about what other industries have done. I flew on Delta a couple of months ago, and the only choice was for me to check and tag my own bag, which I failed at very miserably. But, people are willing to do things electronically. That is one solution to some of our staffing challenges, that we don't need people doing that. We don't need people filling out the same form 6 times. We don't need to have staff even doing that when people can do it. And so we're investing very heavily on the technology side of the equation from an experience perspective to connect their journey. And again, it helps solve some of these other problems that we've been talking about.
I resemble that form remark in terms of my practice. We've gone from 6 to 5 forms, so we're just really making big changes at Duke, Kevin.
We're fortunate at the conference to have a lot of young people who are entering the healthcare field or considering it. Jonathan, for kind of the last question for everybody, what kind of message would you like to give to them in terms of this as being a career of healthcare?
Yeah, great question. So I would say I don't think you could have made a better selection and choice in your career. Yes, I'm biased, but also because I think the timing right now, as we talked about and have gone over some of the challenges and opportunities in our respective industries and organizations, I think it comes with a sense of just enthusiasm and energy. I'm very optimistic about the future. I had the privilege of meeting one of your administrative fellows yesterday at the reception, Alex, extremely bright young man, was excited to talk about his rotations and the things that he's learning and doing. I encourage other health systems, if you don't have, to please stand up an administrative fellowship opportunity to give students and to give these young future leaders the opportunity to engage and learn in your organizations. So from a standpoint of just what words would I leave with you, please embrace flexibility, embrace the spirit of tenacity, and embrace the true spirit of passion around quality and patient satisfaction. You do those things, your career will sail.
Tom, your turn.
Very well said. First, I'll say Alex has a job at Duke, but he is very good. I would share Jonathan's enthusiasm. This is an extraordinary time in healthcare, and we've been through something none of us had ever imagined, and we see great opportunity. We need talented, dedicated, mission-oriented people, and I am very excited and enthusiastic about the future of healthcare and see the promise actually in many new team members joining us and charting that course, because their perceptions, their ideas, their view of what healthcare should look like is going to help us drive the change that's needed. So it's a great time to go into healthcare.
Kevin?
Sign up at Piedmont.org under careers. We have plenty of openings. Anybody in the room needs a job, I'll get you one. Anyway, I grew up in healthcare. My father was a rural hospital CEO in rural Wisconsin. Grew up in a town of 6,000 people, and my mother was the only nurse practitioner in town. And I grew up with patients calling my mom all day and night, and she happily took those calls. And whether it was their child didn't have a straight bowel movement, or whether something that was just helping them out, it gave me this great empathy for just helping people. And it's a noble cause. It's a great profession. You get to go home at night and go, you know what, it doesn't matter if I'm in IT or I'm on the front line or I'm in administration. I got to help people today. And there's not a lot of industries that can say that. And it's just, you have great pride. Doesn't matter. These are three great organizations. Again, you feel good about the work. It's tough work, but at the same time, it's just the purpose, the cause. Yeah, I get no greater joy than somebody calls me and says, you know what, my mom has this going on, or my friend just got diagnosed with breast cancer. What do I do? And I say, I can help you. I'll help you navigate and get to somebody that is going to, that I would trust with my own family, and they're going to help you out. And you can just feel this sense of relief. You just don't get that in other organizations. In a prior life, I worked for an organization where one of my board members was part of the Nordstrom organization, and he said that to me once early in my career. It was just, we have a great company, great stores, we make a great living, but we don't have the ability to help people like you help people, and that's always something that I've carried with me. And again, there's just a great pride in working in healthcare, and so proud to work for Piedmont.
Well, you three did a tremendous job. We thank you for sharing your thoughts, and why don't we give them a round of applause? Thank you very much.